And at this point, I'd like to turn it over to Dr. Jim Battles from the Agency for Healthcare Research and Quality, who will describe for you some very important activities that AHRQ is undertaking for prevention of CLABSI and other HAIs. Jim?
Thank you, John. It is a real pleasure to be here. I'm going to talk a little bit about what we're doing on a specific intervention program for CLABSI, the CUSP for CLABSI, or what is known as On the Cusp Stop BSI. Next slide. I think one of the most important things I wanted to frame what we're doing is that if you're really going to eliminate or mitigate CLABSIs, it requires more than just measurement. There's an old Midwest saying that a pig never gained weight just standing on a scale. You really actually have to do something to intervene. Next slide, please. So that you have to begin to focus on actual changes in clinical practice. So in those practices, you need to focus on at the unit level in the ICU or the hospital unit. And the other aspect, sort of philosophical, that infection prevention control is not just a problem of the infection control professional. You really have to have activities that engage all frontline professionals. Everyone needs to be involved in solving these HAI problems, from the CEO of the hospital down to housekeeping personnel. And it also requires a bit of a culture change, or actually a major culture change too. Next slide, please. Our change intervention program is called the Comprehensive Unit-Based Safety Program, or CUSP. Originally developed at Johns Hopkins by Peter Provost and his colleagues in the ICU and other units at Hopkins, we then moved the concept of CUSP to a large-scale test in the state of Michigan in a project that was referred to earlier, the Keystone Project, which was funded by AHRQ beginning in 2003. Next slide. This slide shows kind of the breakdown between those generic activities that are the clinical change that are generic, the CUSP activities. And there are 5 components: the education of staff on the science of safety, identifying defects, assigning executives to adopt the unit, to get the top-level engagement, learn from defects, and then implement teamwork and communications and safety culture. Now, the specific activities, the interventions directly related to CLABSI would be washing hands prior to the procedure, maximal barrier protection, preparation of skin with chlorhexidine, again, avoiding femoral lines, and obviously remove unnecessary lines. So a CUSP program, depending on the nature of whether it's an HAI or other activities, would have generic activities of change and then specific activities for the individual intervention. Next slide. Obviously, with the results from Michigan, we were faced with the question, well, will this work elsewhere, outside of that one state? We believe that the progress rate was such that other states would benefit. So we launched the national implementation of CUSP for CLABSI, and that is known as On the Cusp Stop BSI. Next slide. The project goals for Stop BSI are to reduce BSIs to 1 per 1,000 days. Obviously, in some states, they view CLABSI's elimination as the goal, to get to 0. We wanted to have the program reach all 50 states and the District of Columbia and Puerto Rico, and include both ICUs and other units with BSI risk. We also wanted to make sure that we included critical access hospitals and that we would improve culture. Next slide, please. The leadership for this project, the contract with AHRQ, is with the Health Resources Education Trust, which is a component of the American Hospital Association. The HRET and the American Hospital Association would work through the network of state hospital associations to organize activities at the state level. Obviously, JHU and the Quality and Safety Research Group under Peter Provenost's leadership are playing a major role, as well as the Michigan Health and Hospital Association, the Keystone Center, which is handling the data for the project. Next slide. For a variety of reasons, we approached this project in a phased rollout across the country in groups of cohorts, and this particular map, color-coded, represents the different colors of the cohort as we moved across the country. Next slide, please. Well, the important bottom line question was, how are we doing? Well, we have 46 hospital associations and one umbrella group participating, and that represents 1,055 hospitals and 1,775 hospital teams. Obviously, some hospitals have more than one team participating in the project. 22 states began the project in 2009. 14 states, the District of Columbia, began in 2010, and 9 states and Puerto Rico began this year in 2011. Next slide, please. Well, we do have results from the first 4 of our cohorts. Cohorts 1 through 4 starting in 2009 and 2010. They had a baseline rate at the beginning of when they started of 1.87 per 1,000 days. After 10 to 12 months, the rates decreased to 1.25, a reduction of 33%. I think the other important piece of data is the percentage of units with 0 quarterly CLABSI increased from 27.3 at baseline to 69.5. The next slide. And this graph shows you that length of getting to 0. And I think this is a major conceptual change, is that, in fact, the goal of 0 CLABSIs may very well be obtainable in some hospitals and units. Next slide. This last slide shows by type of hospital their reduction over the period of time. The very dramatic purple line, if you can see the color, is from critical access hospitals, where they went from a fairly high rate to basically 0 over the period of time. Pretty dramatic change. So the different colored lines you can see as people are beginning to get closer and closer to well below 1, and some are going to approach to 0.